Los Angeles, and previously the co-director of the Chordoma Center at Mass General Hospital in Boston. Dr. Schwab's going to speak on the role of patient-reported outcomes in chordoma care. So Dr. Casery mentioned the quality of life assessments as part of clinical trials and understanding the clinical benefits, so improvement in side effects that happen with some of these drug therapies. But Dr. Schwab's a surgeon, so that also comes into play in other areas of treatment for chordoma. So Dr. Schwab's been instrumental in integrating PROs into clinical settings and helping us better understand how treatment impacts patients' lives and advancing these patient-centered approaches in chordoma care. So welcome, Dr. Schwab. Thank you.
Thank you very much. This is a little bit of a different perspective, and so some of my talk would be pertinent for folks that have metastatic or recurrent disease, but in part of one of the questions that was asked earlier about where do we see the future and reevaluating how we're treating primary disease, right? And looking at perhaps different outcomes. You know, traditionally we looked at local recurrence primarily, right? And so we have very aggressive treatments, and that can really affect your quality of life. And so quality of life is a really important part of this, even in the primary setting before you've had any treatment. And so that's one of the things that got me interested in this, and I'll talk more about that as we go. We do have a patient-reported outcome measure that we've iterated several times, and this is the newest iteration. We're trying to get folks, especially folks with chordoma, to fill this out and to share it with their friends and neighbors, unfortunately, that do have chordoma, and to get their thoughts on this as we try to improve this outcome metric, and I'll explain further as we go. I don't have to explain to this group that chordoma is not like other tumors, right? It's very, very different, and fortunately it's rare, but it's also a problem that it's rare. Paradoxically, it's slow growing, but also locally aggressive. You know, it has all these different features that are unusual. And as I said, local treatment can really affect your quality of life permanently, and you know, that has been espoused, and as a surgeon, certainly there are times when we render pretty aggressive treatment with the idea that we're trying to prevent local recurrence, but there's certainly a cost. And as we talked about earlier, if the disease comes back or spreads, we don't have known effective treatments for everybody. There are you know, small percentage of patients that are responding, and we're trying to improve this. But there's a lot of opportunity to improve care for patients with chordoma. So looking at this from a positive perspective, we can improve things. And I do hope that in our lifetime that we're not treating patients the way we are right now. The way that very aggressive surgical treatment that I rendered, my hope is that we're not doing that at some point, right? Because that means we've made improvements, particularly with systemic treatment, and that's my hope. I want to point out a paper that we wrote, not to describe the outcomes of the paper, but to discuss the methods of the paper, which I think are very important with regard to chordoma, and to illustrate how different it is from other cancers. In this paper, this is data from Mass General, we chose to follow our patients. These are primary chordomas, patients who had never been treated, and we said, look, we need to follow our patients. To be included in the study, had to have a minimum of 5 years of follow-up. Minimum of 5 years of follow-up. And now if they had a recurrence, they were included in the study, but if they didn't have a recurrence, you weren't included in the outcome metric until you had 5 years of follow-up minimum. Followed our patients for a median of 9 years. That means 50% of our patients had more than 9 years of follow-up. Why are we doing that? You know, what's the importance? And the reason we did that was based in part in our experience and in part on data that we'd looked at from a larger sample size. So what I want to point your attention to is this is for primary chordoma. The average time to local recurrence is 5.5 years in our 5.5 years. So, and the average time to metastases was 4 years. Most cancer studies, if you have 2 years of follow-up, that's considered, you know, sufficient, right? And there's certainly lots of papers in chordoma that have less than 1 year, less than 2 years of follow-up. But what that does, the problem is that it inflates the effect of your treatment. It looks like your treatment may be working quite well, but with more follow-up, the patients recur or develop metastases. The reason that's so important is if we're continuing to publish papers with that level of follow-up, we're not going to improve care, right? Because we're going to assume that this treatment is reasonably good, even when it's not. Right, so that's why it's so important, and why I try to to emphasize when you're looking at papers, have to look at follow-up, particularly in the primary setting. So, okay, fine. So where does that lead us? Well, the difficulty is, if you want to construct a clinical trial to study the prevention of local failure, local recurrence, or the prevention of distant metastases, you have to follow patients for a very, very long time. It's difficult for patients. It's difficult because it's expensive, right? There are almost no trials that follow patients that long. And so it makes moving the needle more difficult in the primary setting. And the tumor tends to be slow growing. So how do you know if your treatment is working? This was talked about a little bit earlier. Do you base it on, does the tumor have to shrink? Well, traditionally, yeah, that's one of the metrics that you look at. Or do you have to stop the tumor from growing? Is that sufficient? Or maybe you just slow the tumor growth, right? But then it goes back to, well, how fast do these chordomas grow? I still remember very clearly, I was a junior faculty at Mass General. There was a radiation oncologist at that time, he's now retired, Norbert Liebsch, and he had a very large chordoma practice, and he showed a case, very large tumor, and had been biopsied, and it was confirmed to be a chordoma. And he talked to everybody about what they would do, and we had it all lined up. We were going to give radiation, surgery, and then he showed us the next slide. He goes, that was 13 years ago, and this is the tumor now. It hadn't changed a bit. And so, you know, that happens, and you think, well, what is going on? The immune system, what is it about that? So there's a lot we don't know about chordoma, which was, I think, brought out earlier with some of the discussion. These tumors are unique and they're rare. Let's see. So, you know, the NIH and the FDA began to look more closely at other means to assess response, other than, say, overall survival, for instance. And they started to look at measurable content to approve drugs. That changed. That really changed how drugs were approved. And at first they were looking specifically at overall survival. Does your treatment affect overall survival? Well, fortunately, patients live for a long time with chordomas, right? But that doesn't mean they're not getting lots of treatment. So just looking at overall survival is not the only metric. So you have to look at things like progression-free survival, and that evolved over time, right? And so again, as discussed earlier, looking at how do we assess progression. And again, for those of you that are, and everybody is interested in this based on the conversation, these are the RECIST criteria, right? To understand, what does it mean? So if you have progression of disease, what is that definition? What does that mean if you're on a clinical trial? It means you either have a new lesion develops, or one of your lesions grows more than 5 millimeters, or, and this is where a lot of chordoma patients are, that you say have a 20% increase in the sum of the diameters of up to 5 lesions. It's a little bit complex, but this is where you're starting to figure out, is this progression, is it not? This is important. These definitions are important because it can be the difference of a drug getting approved or not approved. What about a complete response? That's the grand slam, right? The tumor goes away. We all want that. That's what we're all looking for. But we'll accept a partial response. And what is a partial response? At least a 30% decrease in the sum of the target lesions. These are the definitions. These are important, right? But the NIH and the FDA, even in the 1970s, was stating that quality of life is important. And we need to look at the quality of life in the context of these outcomes. And so, you know, the question is, how do we do that? That's patient-reported outcome measures. And this is really just the idea that patients can fill out these prompts, and they won't be filtered by the surgeon or the treating physician. They're directly from the patient. But then it begs the question, which ones? How do you develop these prompts? And this is what started us on this path over a decade ago. So one of a meeting that we had with a series of my colleagues was held at Sloan Kettering in 2000, at Memorial Sloan Kettering in New York in 2013. And we got together, folks from the Mayo Clinic, from Sloan Kettering and Mass General, where I was at the time, and we convened a meeting that had multiple different disciplines, including medical oncology, you can see the list there, ENT, colorectal surgery, very large group of physicians, for 2 days discussing quality of life and discussing how do we measure this in patients with chordoma. Now this was particularly related to sacral chordoma, but certainly there were discussions of clival chordoma there and also the mobile spine, hence the ENT and some of the other disciplines that were involved. But if you look at Sacral chordoma, one of the things that we talk about when we look at functional outcomes are at what level is your tumor, because that's going to dictate what nerves may need to be sacrificed, right? And that's going to have a huge impact on your quality of life. Just as an example, the close-up of the sacral plexus, and to illustrate, some of the nerves in the sacral plexus become the sciatic nerve. So the sciatic nerve, that's lower extremity function. If you lose your sciatic nerve or part of your sciatic nerve, you're going to walk differently, right? If you lose all of your sciatic nerve, it's going to be hard to walk. What about the lower sacral nerve roots? Well, those become what's called the pudendal nerve, and this is something that a lot of people don't understand, a lot of doctors don't understand. Pudendal nerve, S2, S3, and S4. They coalesce and they give branches in your pelvis, to your rectum, to your bladder, to your genitalia. So if you remove those, you're losing bowel, bladder, and sexual function. That has a huge impact on your quality of life. I mean, it's life-changing event. I'm going to pause for 1 second. Think about it for one moment, because I've had several patients, they come to my clinic and they're healthy patients and they're not having symptoms. And you say, okay, this is where the tumor is, and if we remove this, you're going to lose these functions. And they're immediately say, no way, and I understand that. Who in the right mind started doing these surgeries? I'll tell you who. Well, no, it's like, who would do that? Who would do that? It would be a surgeon who saw patients whose tumors grew and took away all those functions. Tumors that become massive tumors, patients are in terrible pain, they lose their bowel function, they lose their bladder function, they lose their sexual function, eventually they lose their life. That gave the surgeon the courage to say, we have to do this, because I've seen the other side of it. Most people don't see that anymore, and so it's hard to imagine why you would think that. But that's what happened. That happened in the 1970s. A surgeon named Bertelsteiner from Sweden, and he wrote a paper on this because he had published a paper where every patient had recurred when they did nerve-sparing surgery and low-dose radiation. Every single patient recurred in the sacrum. And he saw what happens. And so that's where that's coming from, because it seems so barbaric to do these types of surgeries. And that's where that started. I think the context is sometimes helpful, especially in the modern era, where it seems a little bit out there. All right, so after this meeting, we chose 6 domains. And these domains were in part related to where chordomas occur all over the spine, but we did pay special attention to bowel, bladder, and sexual function. But you can look and see lots and lots of questions that we were asking patients to fill out. And we ended up publishing a paper about this, which I'll describe. When you're developing proms, you have to take certain statistical assessments into play. So for instance, floor and ceiling effects. You don't want to have these, meaning if you have a domain where everybody gets 100%, that's great, we want to get 100% on our test, but some people might be getting a 150. You're not figuring out who's really doing well. Even worse, if everybody's getting 0, some people may be doing really, really badly. You want to be able to understand who's doing what so you can help them, help the people that are really suffering. You don't want floor and ceiling effects, so it's something you need to look at, and we have looked at for these proms, as I'll describe. There's something called Cronbach alpha. So I told you there are 6 domains, right? One domain is pain, one's physical function, one's bowel. In that domain, you want those questions to be fairly consistent, right? You want the in-domain questions to be consistent, and that's measured by something called Cronbach alpha. Maybe more information than you want, but this is how it's done. The other thing you want to look at is correlation. You don't want all these domains to correlate. You want them to measure something specifically different than the other domains. Otherwise, you're asking patients to fill out too many questions. So if you have high correlation between domains, that's problematic. Content validity, and this is where patients are a huge part of these prompts. And we had 80 patients fill out this initial survey, and then we asked all those patients to write comments. And this was a different time, so they were writing them in the margins. Those 32 patients that responded had a huge impact on what happened with this prompt. And that's why in the prompt that you'll see, there are comment sections. We want to hear people's comments. And I'll explain where this went. So what did it show? The statistical analysis said fair amount of redundancy, too much correlation, meaning we're asking the same questions. What did the patient say? It was way too long. Lots of people said that. I had to shorten it. The other thing that patients said that we hadn't realized is we weren't asking them any questions about their social life, their social function. None of our questions were involving their social function, which is really what was impacting them. People can deal with lots of different things, but their social life was changed dramatically. And they wanted that to be measured. And so that changed the next iteration. So this was the next iteration. And I said we decreased the number of questions, and we did. But we increased the domains. We went from 6 domains to 7 domains. We added the social life domain to it. One of the things that you'll see is we're trying to use something called PROMISE. And that's an NIH-sponsored questionnaire bank that is, the nice thing about it is they have normative data. So you can compare your results to the overall US population, which is useful. And most of them have what's called computer adaptive testing, so you don't necessarily have to answer all the questions to be scored. All right, so this was then given to 70 patients, 70 of our patients at Mass General, and we have been doing an analysis. In fact, as I say, I'm not there anymore, but my former partner is writing up a paper with this analysis. But I'll just give you the cliff notes. There was some ceiling effect noted in several areas. The other thing we noticed was we weren't asking people, there were some binary questions that we were missing. Do patients have a colostomy, or do they not have a colostomy? Because if you're asking people about constipation or problems with their bowel and they have a colostomy, there's different issues associated with that. We weren't asking people if they were self-catheterizing. That has an impact on their life, has an impact on how they're answering some of these incontinence questions. These are also so pertinent for spinal tumors as well, if somebody has a spinal cord injury. We also didn't have any room for these surveys for patients to make comments, and I think that's problematic for the reasons I mentioned earlier, so we're changing those. So the updates on the newest iteration, we've tweaked some of the questionnaires. We're still using PROMISE. We are using computer adaptive testing, at least once we put this into full adaption. And then we're asking questions, as I mentioned, about colostomy, self-catheterization. So our goal is to develop a patient-centric questionnaire that helps us understand the personal experience of patients with chordoma, right? And I mean, why? What's really what we're trying to dovetail an understanding of patients' experience with the treatment options, because everybody is different. I've had patients say, I'm okay with losing my bowel, bladder, and sexual function. I want this tumor out, and I want the best oncologic result possible. And I've had others say the exact opposite to that. And we have to be able to tell people what their outcome could be, functional outcomes. If we can give them a better assessment of that, talking to other patients in advance, it helps people make decisions. People will make different decisions. Not everybody's going to go for the aggressive treatment. That's just, everybody's going to be different. So it's very, very important for us to have a good quality of life assessment. The other thing that's happening is that the FDA is recognizing, hey, wait a second, we keep saying quality of life is important, but what about having quality of life as a co-primary endpoint? Not just did the tumor grow or not, but what is your life like during this? Because we're hoping people are going to live for a long time, and if some of the side effects are permanent, we need to know that, right? And so perhaps that should be a co-primary, or in some cases a primary endpoint. As I said before, if you have primary chordoma and you have to follow patients for 5 to 10 years to find out if your treatment worked or not, what about having a quality of life metric at 1 year, 6 months, 2 years? Those are primary endpoints in the short term, and the long term are the cancer-free statistics. These are thoughts, these are movements that the FDA is verbalizing, but we're not there yet. And we're not there yet in part because we don't have accepted quality of life surveys. And the only way to get those is by iterating, is by asking patients to be involved and doing these sorts of studies that we're trying to do. So with that, I'll stop, and I'm happy to answer any questions about this or chordomas generally. AI. I'm actually I'm a data scientist, so I do have some thoughts on the AI and chordoma as well. So anyway, please.
So have you been evaluating the results of these as you've been tailoring the
what
questionnaire?
happened was the second iteration of the survey had been collected on paper. First it was in REDCap, and then somehow that got taken, so we were just doing it on paper. So I had a stack of these questionnaires, and then all of a sudden I went from Mass General to Cedars-Sinai. So my partner, I said, look, don't lose these. We have to study these. So he's studying them, and now he's doing an analysis. And in fact, he sent me a couple days ago a laundry list of statistical analysis that they're doing. So the answer is yes, and that will be published.
But they're institution by institution.
Well, that it turned out it was supposed to be this whole consortium was really Mass General, was Sloan Kettering, was Mayo Clinic, and it was also University of Toronto. They all contributed to the original model. But then when it came down to asking patients to fill out the second iteration, nobody did it except Mass General. So I'm trying to reinvigorate that again by saying, look, here's the data, here are the changes. Please, everybody, fill it out.
Right.
Ask your patients to do this so we can learn from it.
Right. I fill a huge one out every time. That's funny. When I was first diagnosed, it was on paper, and now it's digital. But I'm an MD Anderson.
Yeah.
So will those ever assimilate? Ideally.
So MD Anderson, we're having another meeting with this group of people, and we're going to talk about these. And MD Anderson's going to be there. And so MD Anderson's leading the way in functional analysis, which is great. And I think that will be part of the future as well.
Amazing. Interesting. Very cool.
Did you have a question?
What if I want to take this promise? How do I go about doing it?
You just take your cell phone and it's right there. That's the QR code that'll take you.
I missed the square.
Yeah, it's the same one that's on the sheet that if you want to fill it out.
Also like that whole functional whatever stuff. Oh my God, that's amazing. I would have loved if somebody would have sat with me and went over that.
Yeah.
And I don't think it's still too late, so I would love to schedule an appointment.
Anytime,
Put
yeah.
it in your pocket, so that you can go over that. Because that would help me to understand why, because all the time I'm like, well, is this normal, is that normal? Well, it's kind of hard to say, when it comes, and well, based on your surgery,
Yeah.
I'm like, I just want to have, somebody tell me it's not in my head, and no one ever,
So
they want to explain that. The sacrum, the nerve,
Yeah.
the feet, the legs, they kept telling me and reassuring me that it was nowhere near L5,
Wow.
and it was not going to affect my walking or anything.
I honestly.
want to kiss you right now.
No, one of the things, I agree with what you're saying, and I saw this, at different times in my career, and I remember thinking, we have to be direct with the patients and say, because, the answer is, well, we'll see, everybody's wired differently, we'll give it some time. I tell everybody that, so look, either for sure you're going to lose function if I know this.
And
This is what you're going to lose.
Walking in and I'm blood, black and white, hit me
Yeah.
hard.
Well-
Tell me worst case scenario.
That's right, and so there are times when I've told patients we're close to the nerves, but we're not going to plan on taking the nerves, but you still could lose all of your function. Because it's true.
Yeah.
The fact is that it's not just the nerves. It happens. You're changing people's function because it's not just the nerves, it's the muscles. There's a lot that goes into how your body works that, frankly, our understanding of physiology isn't as advanced as we'd like to believe it is. And so the nerves may be all there, things aren't working properly. And that's the reality.
And just so you all know, these slides will go out to all of you. So if you right now aren't able to, with the QR code, you will be able to access this.
The conversation as well.
Yeah, please.
I'm not seeking a diagnosis of me.
Yeah.
But it's a general question, I'll try to be very specific. The last scan, the technologist said it's invading the abdomen, and there's a buckle on the liver, which I don't know what he meant by that. And so my question is, it seems like you should be able to just go into soft tissue, like in the abdomen, and just cut the tumor out. And I'm not sure that's possible. I'm wondering what you have to say about that option.
It can be really tricky, and for instance, the liver, depends on if there's a lesion in the liver, where is it in the liver? There are technologies like ablation and things of this nature that you can do with imaging, but it really depends on where the liver or where the lesion is compared to a large blood vessel or, yeah.
Does it hook to the liver? I mean, does it come from outside and just hook onto the liver?
Usually inside the liver itself. So you can imagine it spreading, it gets into the liver and there'll be a nodule inside the liver itself, usually.
And you can't just take it out?
So it depends on the size, but there are techniques where the interventional radiologist can put a probe, they'll under a CT guidance, they'll put a probe into the lesion. So I'm doing this because I'm watching the screen. They're watching the screen, they see the probe go inside the lesion and then they freeze it or they burn it. And so it's that, when that happens, that's called an ablation. And so that can be helpful in some circumstances. It's not possible in all circumstances, depending upon how close it is to structures that you can't burn or freeze without having a major side.
I'd like to ask a question. I'm newly diagnosed 2.5 months ago. I had no treatment yet. I've gone through all the surgeons. Do it, don't do it, do
Yeah.
it, don't do it, the whole thing, and so I'm making a decision. I am coming closer to doing the proton
Yeah.
therapy because we went out to Minnesota to the Mayo Clinic there.
Yeah.
The surgeon plus the radiologist and everybody said because of my age and recovery and everything, they thought that proton would be more effective for me. In fact, they also said that some of their studies have shown that their beginning studies that the survival outcome of doing just radiation compared to doing the surgery will be very comparable soon. So my thoughts, and of course, because I'm just beginning the
Yeah.
journey. How do you feel about not doing surgery at all and just doing the proton?
So I think, so we had these discussions all the time when I was in Boston, because we had a strong proton center, and we had strong surgical, strong surgeons as well.
They're all fighting against each other.
Yeah, that's right. There's a bit of competition there, right? And so the looking at again, there is actually a study trying to look at this using carbon ion versus surgery. But at Mass General, we had patients who elected for protons, so that's a select group, and then patients that had surgery plus protons. So we would treat patients and with preoperative protons, then do a resection, and then do postoperative protons, versus doing protons themselves. And the data that I would say that I've seen is that protons can work very well. They're not oncologically as good as surgery has protons, but the side effects are much less. So it comes to a quality of life issue. And if you're 16 years old, you've got a long time for that tumor to be there, and it's concerning. This is the paradox. This is a paradox. So you have a 16-year-old patient with a sacral chordoma, and I had this exact experience. So are you going to say, well, we should take the tumor out because you're so young, doing proton? On the other hand, you're so young, you're going to lose all this function for the rest of your life. It is true that it's a bit of a race, right? You know, the protons can be effective, and there's lots of patients that have been treated definitively with protons. And the thing is, how long will you keep the tumor at bay? Usually the tumor shrinks after a few years, but it doesn't usually disappear completely. So the question is there active tumor there? We've seen patients 10, 15 years follow up with no change in their chordoma after protons. In other cases, the tumor starts to grow again. And so it's not a panacea, none of these treatments are. I think that it can be effective, protons themselves. If you want to compare the two, just an oncologic answer, oncologically it's better to have surgery and protons, and that's just my bias. But it doesn't mean it's not okay to have protons themselves. I think for somebody over the age 50, over the age 60, you start to get into this. Yeah. So a 70-year-old person, you know, you're sort of now in age is so relative now. 70, you used to be 80, you never operated an 80-year-old, but now plenty of 80-year-old folks are operating. Anyway, the point is that I think it's reasonable to consider protons. I don't think that the cancer results are quite as good. So if you live to 100, you know, it might have an impact. Do you see what I mean? That's kind of a vague answer, but that's because I don't really know, and I'm trying to give you my honest answer.
That's why we need a blood test.
Yeah. Well, that's why, like I said, I hope that we're not doing these really aggressive, terrible decisions that you have to make, you know, as a patient, you know, because it was really interesting at this conference in 2013. One of my mentors, who's now semi-retired, Patrick Bullen, some of you may have met him, he asked everybody, all the surgeons, well, what would you do? And, you know, and everybody kind of gives an answer, but if they're by themselves thinking what they would actually do, it's not so straightforward, right? It's not straightforward for anybody to make that decision, right? And not for surgeons either. They may say it in public, but in private, they're going to give themselves pause. That's not an easy choice to make.
I did ask him that. I said, what would you recommend for your mother or relative
Yeah.
or anything? And the surgeon said, I would do proton before I would do surgery. That's what he told me.
Well, That's fair.
My age and my.
That's a very fair, honest answer. I think that's a very fair answer.
If the tumor started to grow again, could you have proton therapy a second time?
There's a limit to how much radiation you can receive. That's the problem. So, you know, you would probably get 78 gray of protons. If you're trying to treat it definitively, it's 78 gray. If you're treating it as an adjuvant to surgery, it's 72 gray. Sometimes there's some room depending on where the tumor starts to grow again, but you're limited. You're limited by how much radiation you had previously.
And surgery after having radiation, if it's like 5 years after radiation,
Yeah.
what's surgery like?
So if you're giving radiation at the time of your initial treatment, like preoperative radiation, then surgery, it really doesn't affect the surgery in the actual technical surgery. It does affect healing. But 5 years later, it's really tough. The surgery becomes more complex, and then for that reason, the complications of surgery go up. Wound complications are probably the #1 problem. If you have a wound that doesn't heal, so you have to, if you're going to have radiation, you have to have a flap. You have to have plastic surgery really embedded in this. This is the lessons we learned at Mass General, because that really will help mitigate the side effects of radiation. One of the big ones is our wound complications. The other thing is bone healing. So if you have radiation, it really kills the bone, the healthy bone cells. We've done studies where there's no healthy bone remaining, and so the spine doesn't heal, the sacrum doesn't heal. And so if you want things to heal, you have to take vascularized bone, either from the fibula or a vascularized rib. You have to be very, very aggressive with your treatment. So surgery becomes more aggressive because the reconstruction becomes more technically challenging for the patient to go through. But those patients, if you get them, they have no wound complication and their bones heal, that can be a good outcome, but not without its morbidity for the patient. Yeah.
If you had surgery with no radiation, have you banked the radiation option for later on?
And this is what most people do. So most surgeons, most groups do not agree with what I'm espousing as the best treatment. So realize that I have a bias. I trained in a place where we use radiation. Most people say, I don't want to give radiation. I want to avoid the complications. If my margins are close, we'll give radiation afterwards. And that's what many, many people do. So yes, you do bank that radiation in the sense that you can still give it. Our experience was, though, it can be very difficult to salvage when you get a recurrence, because you get one recurrence and then another one pops up. And then, you know, it's very difficult to treat a recurrence. That's what we found at Mass General, even with protons.
Thank you.
Thank you.